Biomedical risk, it comes under the government remit, right? So that box that you see, it's part of the government-funded TI systems. But where we feel that the transition to communities is still work in progress, or it's unfinished business, is that when you're talking about those boxes, issues in service delivery, structural barriers, the other economic and financial vulnerabilities, it's more a social, cultural, behavioral change, right? And it takes more than a decade to work on those issues. So that's what we are focusing on, and these are the 5 broad themes, right? So when I talk about advocacy for service delivery, how do you ensure that you're capacitating the communities to have a voice, right? And it's not necessary, most people assume that it's meant to be confrontational, right, and antagonistic. It need not be that way. Our whole agenda is to, if one can call it intelligent activism, how do you arm the communities with data? How do they look for data? Who do they negotiate with, right? So today there are issues on the ground of, one hears of commodity stockouts, whether it's ARV drugs, condoms, STI kits, etc. But do you get into a confrontation, or do you have, smart reporting systems where the community is able to collect data and take it to the next level? And that's when you build credibility for yourself, right? So these are some of the elements that you're working on. If you look at the 4th bucket, the financial inclusion piece, I'm not an HIV expert. My experience is limited to what I know of Avahan. But if this is done well, it can be a game changer, because, at least theoretically speaking, what keeps a woman in sex work is that she's in constant debt, right? So if you go to a state like Andhra Pradesh, every sex worker has taken loans from 3 different money lenders, sometimes at 100% interest rates, right? So she can never pay that off. So for the next 20, 30 years, she has to be in sex work. And there's absolutely no understanding around savings, how to get bank accounts, right? So we're talking about very fundamental issues when you're talking about financial inclusion here. And just given the current environment where the government is very keen on pushing what is called as the Jan Dhan Yojana, right? It's about opening bank accounts, getting more people to save. It also resonates with what the government wants to do, right? I won't spend too much time on this, except to say that, we see a lot of merit in sharing what we have learned from the more than decade-long Avahan experience now. So we have already been through a very intense 1-year learning kind of a project with the northern states, right? So interestingly, if you see these HIV surveillance data, HIV is stabilizing and declining in the southern states, and it contributes to only say around 31% of the overall emerging new HIV infections. Whereas the earlier, what was assumed to be the low prevalence states in the north is where you see an emerging epidemic. So we see a lot of value in sharing lessons within India to the northern states. And of course, Africa is, maybe we can talk about it later, Lisa, but I just want to say that just based on, initial landscaping, we see a lot of portability of Avahan's lessons in the context of at least the concentrated pockets of epidemic. And we already have a grant with the Kenyan government. It was meant to be a 3 years grant, but again, based on how things are progressing positively, we just made a supplement, and it's becoming a 6-year grant with Kenya. Okay, so it wouldn't be appropriate if I don't talk about the current situation. So obviously it's not roses and daisies all the way. So while the transition process by itself worked very efficiently, and we still continue to support the government, the current environment, I'm sure you're hearing a lot of noise coming out of India, various articles, is that overall there's been a budget cut, right? So especially social sector funding, which includes health, it's seen a 30% cut in budgets roughly. And obviously there's an implication on HIV, right? So if you look at the numbers there, for this particular financial year, which is 2015-16, there's been a significant reduction from, I don't know how much would that be in US dollars, but it's a significant cut, right? And what complicates the situation is that this year we are moving to an arrangement where HIV used to be a centrally sponsored program, right? Entirely borne by the central government. But just given the way we are organized, it's going to be a 50-50 kind of an arrangement, and probably in HIV it's a 60-40, where the central government will spend 60% and the states are expected to pitch in with 40%, right? So that complicates things more. And of course, NACO was run like a vertical program, right? It had its own identity. It had a secretary level person heading it. So it had, a lot of push. In the last year, it's got subsumed under the Ministry of Health, right? So that's the other implication on the HIV program. And obviously, India is seen as a middle income country now, and a lot of donors are also stepping off, including the Gates Foundation. So it's like a double whammy, things like this. And this is just to show you visually that, while the overall outlay went up from the earlier phase of the National AIDS Control Program, the phase 3 to phase 4, but in terms of the actual allocation, it has gone down significantly, right? So, yeah, with that, I've overstepped my time.
No, you're allowed. I think everybody's very interested in hearing the details, and thanks very much, Atagi, because I think you set just a great context for the rest of the discussion. And I would just say three things actually really struck me in your presentation. The first was how deliberate the foundation was in its planning, starting around 2006. The second, that it was a relatively low-cost investment to plan for the transition, although it was very labor-intensive. And the other slide that I thought was very interesting was the quality slide. And it would be interesting to come back and maybe talk a little bit more about that, but that there didn't seem to be a compromise in quality as the transition happened. And I should probably also say up front that I actually worked at the foundation when Avahan was getting launched and was involved in some of the early conversations. I don't think that's biased me as a moderator today, but it's quite incredible to hear how this has evolved from the original vision to where it is today. So with that, should we go now to the message from Dr. Dringa? And again, Dr. Dringa is the Deputy Director of NACO.
A very good morning to all of you. At the outset, I would like to thank John Hopkins School of Public Health for inviting me to talk on this topic of transition from Avahan to NACO, that's National AIDS Control Organization, Government of India program. I'm really, at the outset, I'd like to apologize that I could not myself make it because of some ill health. But nowadays, technology makes it easier to send our messages across the countries. I'll take a few minutes before I go really into the transition aspect to tell you about how the HIV program in India is. If you all recollect, during the early 2000s, there were many estimates given about the HIV in India. At that time, India was estimate given was around 5 million cases would be there in India, which really disturbed all the country people, and steps were taken to expedite the national intervention programs. It is at this time, in the year 2003, BMGF came up with the support to the National AIDS Control Organization in the name of Avahan program. The Avahan concentrated mainly in the 4 southern states and 2 northeastern states. And during those time, these 4 southern and 2 northeastern states were accounting for majority of HIV in India. The 4 northeastern states included Andhra Pradesh, Maharashtra, Karnataka, and Tamil Nadu. And in the northeastern states, it was Manipur and Nagaland. There is a distinct about the spread of HIV in these 6 states. The southern states were mainly driven by sex work, while the northeastern states were mainly driven by injecting drug use. In these 6 states, Avahan put up nearly 119 targeted interventions. And at that time, the government program was picking up and the targeted interventions were being placed in the country. The targeted intervention included all over across the country. And in the year 2007, we had around 799 interventions. And that was the beginning of National AIDS Control Phase 3. From 2007 onwards to 2012, there was a big upsurge in the targeted interventions all across the country. In the year 2003 to 2009, Avahan interventions, about 190 targeted interventions were placed in these 6 states. The interventions mainly dealt with reaching out to the high-risk groups or most at-risk population of sex workers, MSM, injecting drug users, transgenders, also looking to the migrants and the truckers. The main thrust of the programs were to reach out to the population and to sensitize them about HIV, prevention of HIV, to make them services available like going to clinical access for STI, getting tested for HIV, and also trying to create an enabling environment so that the interventions can be adopted. Till 2009, these interventions were going on, and in the year 2009, the Memorandum of Understanding with BMGF was approached again, and it was decided that these interventions will be transitioned to the Government of India through state controlled societies. There were 190 interventions, and it was that year 1 will have 10%, year 2 20%, and the year 3 all 70%. That means it was decided by 2012 all 190 interventions will be taken over by the program. The first 10%, which included nearly around 20 interventions, were mostly in the southern states. We set up a process of how transition needs to take place. First is, we decided the parameters or the indicators on which each of this intervention will be independently assessed, and this included around 34 indicators, which included the coverage of the high-risk groups or most at-risk population, condom distribution, condom utilization, access to services, testing, treatment, and also how the enabling factors have been done in these areas. Also at the same time, certain administrative issues were also looked into. The administrative issues included the interventions, how many people, like for example, how many peer educators to high-risk groups. The program said 1:60, but in BMGF, at many places, there were much more in numbers. So when this transition happened, all these things were brought to fore. And at that time, everything was to be brought to the national program outline. So these interventions, which were there, were independently evaluated. The independent evaluators included experts, included community group members, and at the same time also involved state controlled societies and the NACO official also. When this process was set in, each of the multi-stakeholders meetings were held, and each was convinced about the advantages and how the donor-funded or Avahan project needs to be transitioned to the Government of India in the long term. This first phase of intervention was a little bit tricky because, number one, the financing norms of the BMGF were a little different than the government norms. Number two, the administrative setup, which included the peer educators, the outreach workers, and the TI staff, were a little bit different from the program. Also, the BMGF Avahan programs, the testing was not that much as it should have been in the national program. These things were discussed, and all these things were sorted out in the transition. So in the first phase, around 17 interventions were transitioned to the program. This first tranche helped us to resolve many issues with the state, with the community, and try to bring them on board in the interventions. The second intervention, which was around 20%, consisting of around 34 TIs, was much smoother. And this all was in the southern states. The northeastern states were not taken for transition either in the first or the second phase. In the third phase, most of the transition from the southern states happened. But from northeastern states, which was mainly the epidemic which was driven by injecting drug use, there were a lot of differences and the performance was not to that. And this is not because of the interventions, because of the geopolitical area of the northeast. That's why they were there. So anyway, by 2013, the complete transition took place. What I would like to emphasize is, it did not mean only transition. It also meant a continuation of post-transition support for nearly 1 year. The post-transition support included the sensitization of the NGOs to the national program. Because the national program, little bit more stringent, less flexible, and also more monitoring and more supervisory. So those were little bit in which the likelihood of community being not being happy was also sensitized. And this, they took it very well. And if one looks back, all these 200 interventions which were taken up, all have been working well. Until now, there has not been any drop in the quality of the performance of these centers. To the extent when 2012 estimates for HIV were made in India, 57% reduction in new cases happened and 35% reduction in the mortality due to HIV happened. And this is largely attributable to the program's success in the northeastern states and in the southern state majorly. So this is what happens is, I would definitely like to convey to you certain aspects in this transition. Number one, the transition requires a transparency between the donor, between the government, between the state control societies, and also between the various stakeholders that are there. Last but not the least, the community, the NGOs which are implementing these have to be taken on board, and the clear playing ground has to be set. There were issues like we had problems initially in the first phase where there were issues between the Avahan interventions and the national interventions. But by reconciling, realigning the Avahan projects to the national program, it happened smoothly. The aspects that need to be kept in mind is, first is that one should be politically clear that transition has to happen. Like I said, in 2009, we changed the MOU and set up the targets for 10, 20, and 70% transition. This involved sensitizing each player in this game, in which Avahan as well as the Government of India played a crucial role. Once these people are sensitized, then the transition becomes much easier. Another aspect is that we have to convince all the stakeholders that donor funding is not going to go on a million times. And that's exactly what was done. Also, we also took into consideration, while evaluating these interventions, any good aspects that were there needs to be absorbed in the national programs. Examples are, all Avahan projects had very good involvement of the communities, and the communities were responsive to whatever we said. So that was one aspect that we took into our interventions, and then we said we will go ahead and we included in all national programs those areas of community mobilizations. Within the national TIs, certain fundings were given so that community mobilization and enabling factors can be done. Another important aspect that we need to see is that the way it has to be done, the way the transition has to be done, it has to be transparent. We told all TIs about the indicators on the basis of which we'll evaluate. Everybody knew about how it is doing. And if any of these gaps were there, TIs were given time to come up and rectify those gaps. I would say overall the transition of NGO interventions happened very smoothly, and to the extent that at no place did we allow any of the interventions quality go down, or in any way let HIV go up in all these areas which have been transitioned to us. This is how transition worked in India. I would also like to say certain thing more. Though in the MOU with Avahan and BMGF, we did transition these aspects of direct implementation that was through NGO, but somehow there were other non-direct technical support which was given. For example, the monitoring and evaluation tools, the training capacity building manuals and models that were there, all those also were taken into and imbibed by the program. Other thing that happened is the other support which was being given, like the technical support units which were given through Avahan, were continued in the national program. But at the same time, there was certain support which was being given by Avahan. For example, the condom technical support groups. Those were not clearly outlined for transition, but now are being transitioned. At the last, what I would like to say is, if one has to do a large-scale donor implementation program, one should be fully clear this donor has to transition at a given period of time. This period of this transition should be decided. The methodologies should be clearly discussed with all the groups, and the government should make a strong will to take up all these interventions which are costly. The program should also be able to take up the best of the aspects which the donor-funded programs have done. This is how in India we have done. Besides BMGF, we also had USA direct interventions at the same time that we transitioned. All transition was complete in the year 2013. And now no more direct implementation is being done by any of the donor funds. All is being done by national program. And the national program has learned from all the donors and has imbibed all the best parts and incorporated in the national program. I think with this, I'd like to thank you all, and especially I'd like to thank the John Hopkins and BMGF for supporting this talk. Thank you. Good day.
So, thanks to Dr. Drenga, who, as you can tell, has been working very closely actually with Sarah and with the Avahan team for quite a while. Before we actually turn to Sarah next, let me just ask if there's any just clarifying questions that Matangi could help with, either just on her own presentation or any of the points Dr. Drenga made. So any quick, Nael?
Yeah, it might be a question for a discussion later also, but our partner AIDS Alliance India, of course, was a partner in the program, and they've expressed concerns that with the diminishing role of the Gates Foundation and in the context of the budget decreases in general for health, how would you assess the ongoing willingness and ability of the government to invest in prevention for key populations particularly?
Just maybe 30 seconds, and then we can come back to it in a fuller discussion.
No, this frankly is a concern for most of the implementation agencies, and donors like us who have invested a lot of both money and time in India. But what we hear from NACO is that prevention is not going anywhere. It's still very much on the radar. So it is a concern, let me put it this way, that it is a concern, but it's not a catastrophe yet. So if the budgets are going down, in a way, if you look at the numbers, it's like going back to the NACP 3 budgets, so to speak, right? So, I mean, recently I was part of the World Bank Joint Implementation Review Mission, and these were the questions that we raised as a mission to NACO, and definitely they are considering things like, putting together a team which will look at optimizing the available budget to some of the critical areas. But the implications are clearly that, there are certain areas one may need to step off. Right now, what those areas are, maybe there's still, one doesn't have that clarity, right? So we have to wait and watch how things pan out.
Any other clarifying questions?
Yeah, I just wanted to clarify, is the intention for the technical support units to be transitioned as well to government funding, or is the intention for TSUs?
So the transition from donors to, when we say government funding of TSUs, it's the bank funding, right? So in the case of BMGF, by next year, we would like to transition our 2 technical support units in Karnataka and AP. And USAID has similar plans too, right? So over the last couple of years, you see the number of bank-funded TSUs have gone up, right? So it's not government as in the domestic funding that looks at TSUs, but the bank puts in money for that. So there is a transition plan for the TSUs too.
So let's turn to Sarah's presentation, and then we can certainly come back to other questions. So Sarah, you were asked by the foundation to do a comprehensive look at how the transition planning has worked and the execution of that. So maybe you can just say a little bit of background about the scope of work before you go into your presentation.
Yeah, thank you very much, Lisa. And I'm acutely aware that there's probably a whole set of questions and comments that are bubbling here, and we promised that we'd give you an opportunity to talk shortly, so I'll try to be fairly brief about this. But we were invited by the Bill and Melinda Gates Foundation back in 2009 to conduct an assessment of the second phase of Avahan. And if you recall this was the phase that was focused partly on the transition and partly also on the dissemination of learnings. So there was a team at Johns Hopkins, and I put the names of the key players up there. Daniela was one of them, and also a colleague who couldn't be here today, Sachi Ozawa. And we were also working with a group called Amaltash, which is a private for-profit consulting firm in Delhi, but led by Sunita Singh, and we worked with their team as well. So I will focus very much, on the findings from the assessment today around the transition assessment. And I should say in some ways it was a real privilege to be able to work on this, because I think through this series we've been hearing about a series of donor transitions that have taken place, but it's very rare that you actually have the opportunity to conduct an evaluation as that transition is occurring. By and large, people have gone back 5 years later or 1 year later to sort of try and understand what had happened, but we were able to do the assessment alongside the actual transition process. I'm going to speak very briefly around methods, just to give you an idea of how we approach this. Most of the presentation is around findings, and I'm focusing really on 3 things here. One, how was the transition strategy implemented, and what effects did it seem to have? Secondly, to what extent were key elements of the Avahan program institutionalized after transition in terms of the kinds of practices being adopted on a routine basis? And thirdly, what do we know about whether or not program effects were sustained? And I'll conclude with some final lessons and reflections. So starting on the transition assessment methods. This was the goal of the assessment that we were asked to do, to generate practical lessons from evaluating the second phase of Avahan. Obviously, this is focusing this discussion primarily on this process of transitioning to local ownership. But the idea was that this assessment would both guide the transition process as it went along, as well as deriving transferable lessons for other processes elsewhere. So we did have a process whereby we were feeding back findings from the first round of assessment to the actors in country to sort of suggest what seemed to be working well and what was going less well. We started out with a sort of conceptual framework which guided the assessment. There was a very simple almost logic to this. We said, well, there's a series of activities that the Avahan initiative as a whole is engaging in to support transition. Those are meant to lead to a state of transition preparedness. And we identified different elements of that in terms of the NGOs, government being capacitated to take over the program, in terms of there being effective communication around what the transition was, as well as alignment of the program. And that then, after the transition had actually occurred, the key features of the Avahan program would be institutionalized within the government system, and this in turn would lead to a sustained HIV prevention response. And then our questions for the assessment spoke very directly to this. What was the transition strategy, and was it implemented as planned? How well prepared were the TIs for the transition at the time the transition took place? TIs is targeted interventions, it's that acronym of the individual programs. How well institutionalized was the program? Were the program effects sustained? And the sort of overarching question, which was what are the overall elements of a successful transition? We used a mixed methods design. In particular, we relied on a series of surveys of individual targeted intervention programs, as well as a series of case studies, and then we supplemented that with document review, secondary data analysis, and tried to synthesize between those different sources. Sorry, sometimes this clicker seems to work, and sometimes it doesn't seem to work. So
the keyboard might work better.
Okay. I did want to point out that one of the limitations for the overall assessment was really fairly limited buy-in from the government of India. As you heard Dr. Dhingra saying there was a big USAID transition going on at the same time, not quite as large as Avahan, and they were a bit curious as to, well, why are you doing this big transition assessment? USAID is just transitioning, and there's not a big evaluation going on around that, so why do you need one? So there was interest, but not an awful lot of engagement, and that constrained us in a variety of ways. In terms of the transition readiness and institutionalization surveys, these were conducted firstly just before transition. That was the transition readiness, and then approximately 1 year after the transition had taken place. And we conducted them only for the second and third tranches. We came in too late in the process to look at the first round. These were a combination of structured surveys which were targeted at the managers of the programs, and then there was also some open-ended questions. So, you know, they would give us a yes, no, or kind of answer, and then they would explain it as well. For the transition readiness survey that was conducted just before transition, we did a census of all of the TIs that targeted in the second round, and then we sampled from the third round, and there was 80 in total. We tried to go back to